I think that makes sense, right? Or
Had a system update, it looks like. Naturally.
oh, figures. It's always at the most inopportune moment.
Yeah.
Okay. I think we are live. Yes.
Okay, all right. 1:03 p.m. Good afternoon, everyone. We'll go ahead and get started. Paul, do you want to do the roll call, please?
Sure. So I'll go ahead and do in order the agenda. Unlike the agenda, it is employee organizations that is first, not management. I had it switch, but we'll still go in that order. So Shauna Janeway sitting in for Janita Igualier.
Here.
Marlene Fonseca.
Here.
Jose Barba sitting in for Chad Boggio.
Here.
Esteban Lizardo.
Here.
Lisa Palombi.
Here.
Gracie Liu.
Present.
Tony Royster.
Here.
Matthew Rudnick.
Present.
Paul Gerard sitting in for Matt Zabel.
Present.
And Petty Zantos sitting in for Holly Walcott.
Here. All right, thank you. So we can go to public comments. Do we have any public comments?
For those who are on the phone, if you want to press *9 on your phone to put yourself in the speaker queue. For anybody who's in the room who'd like to make a public comment, if you please bring your speaker card to the front. Seeing nobody in the queue online and nobody coming up front.
Okay, thank you. So we move on to the action items. First is the minutes from the June 6th, 2024 regular meeting. Do we have a motion to approve?
I have a quick
Yes.
modification. I'd just like to my alternate, Matthew Crawford, he's of the Office of Finance. So if you can just
Yes.
make that correction, I'd appreciate it.
Thank you for catching.
Yeah, sure.
Yeah, I'll move
Thank you.
approval with that correction.
Thank you.
Second.
All right, moved in second. If we can do the roll call vote.
Okay, we're going to go in the same order. So Shauna, your vote.
Aye.
Shauna votes aye. Marlene, your vote.
Aye.
Marlene votes aye. Jose, your vote.
Aye.
Jose votes aye. Esteban, your vote.
Yes.
Esteban votes aye. Lisa, your vote.
Aye.
Lisa votes aye. Gracie, your vote.
Abstain.
Tony, your vote.
Aye.
Tony votes aye. Matt Rudnick, your vote.
Aye.
Matt votes aye. Paul, your vote.
Aye.
Paul votes aye. And Petty, your vote.
Aye.
Petty votes aye. It's still a quorum of both labor management. The item passes.
Thank you. Moving on to number 4, Committee Report 2501, Staffing Reimbursements.
Report 2501 requests that the committee approve staffing reimbursements for the Employee Benefits Trust Fund for personnel department salary costs of the 4 positions serving the Halliwell program and the 2 positions serving the Live Well program for the first quarter of fiscal year 2024-2025. Attachment A of the report provides the calculations, and the Halliwell program's total reimbursement amount for the first quarter is $153,539.81. And the Live Well program's total reimbursement is $91,766.03. And that concludes this report.
Thank you. Do we have any questions? In the committee? Okay. It's an action, wasn't it? Yes. Do we have a motion to?
I'll move to approve.
Thank you. Thank you.
And just to put it on the record, it's for both A and B, correct? Correct. Okay, then we'll do the order of the vote in the same order. Shauna, your vote.
Aye.
Shauna votes aye. Marlene, your vote.
Yeah.
Marlene votes aye. Jose, your vote.
Aye.
Jose votes aye. Esteban, your vote.
Yes.
Esteban votes aye. Lisa, your vote.
Aye.
Lisa votes aye. Gracie, your vote.
Aye.
Gracie votes aye. Tony, your vote.
Aye.
Tony votes aye. Matt Rudnick, your vote.
Aye.
Matt votes aye. Paul, your vote.
Aye.
Paul votes aye. And Petty, your vote.
Aye.
Petty votes aye. It's unanimous. The motion passes.
Thank you. And so then moving on to informational items, we have a presentation from Kaiser on utilization.
Good afternoon, everyone. Happy New Year. I'm Michelle Dubois, who's the Senior Executive Account Manager overseeing the City of Los Angeles account. And I also have team members today virtually. We have Senior Underwriting Consultant Mark Chopek, who will be joining me in today's presentation. We also have Director Justin Cow of Strategic Accounts, Public Sector South, and Underwriting Manager for Strategic Accounts, Bob Gonzalez, and Senior Workforce Health Consultant Jennifer Barrow. So next slide, please. So just overviewing today's agenda, we'll be going through a utilization summary, a top utilization overview, both an inpatient and outpatient overview, as well as a pharmacy overview and a high cost claimant overview. Next slide, please. I'd like to introduce Mark Chopik, who will be going through all the highlights of today's utilization report.
Hi, good afternoon. Thank you, Michelle. Yeah, so to give us a little bit of a groundwork for what we're looking at here, in the charts on the top right, what we're looking at are the most recent utilization for the last 12 months going through September of 2024, and we're comparing it to data that was used in the most recent renewal. In the most recent renewal, we had data for 12 months going through January of 2024. So what this means is that the most recent utilization has has 4 months of overlap, meaning 8 months of this utilization is new. And as we come to the next renewal, we will continue to see some new utilization come on, and some of these kind of overlap months fall off. In addition, the other comparison that you're going to see throughout the next few slides is the City of Los Angeles alongside the Kaiser Permanente Southern California Health Plan. This is a helpful comparison to have because the health plan shows the utilization changes that we've seen across all groups in Southern California. So when it comes to rate increases or decreases at the renewal time, being able to compare to the health plan is a pretty effective way to understand how much higher or lower than the average rate increase that we expect to see for a specific group. When we're looking at the next year's renewals of the 2026 renewal cycle, those average rate increases have not yet been determined. They're still under work by our actuarial team. So as we get closer to the 2026 renewal, we'll have more information on that. So looking at what we have on the page here, in that top right chart, total claims on a dollar per member per month basis for the city has increased a total of 9% in comparison to that of the health plan at 10.5%. Inpatient is up 2%, which is below that 5.7% of the health plan. Outpatient increased 10.9%, which is below the 12.2% for the health plan. Pharmacy is up 14.8%, which is also below that 15.6 for the health plan. And then within the other category, which represents things like Kaiser Permanente's integrated care management fees, ambulance utilization, durable medical equipment, what we've seen is a fairly on par increase at about 10.3%. Now, outside of the charts that we have in the top right, we have a few graphs kind of across the rest of the page, looking at total claims, inpatient, outpatient, and RX. So looking at those graphs, just so we kind of have an understanding of what we're looking at. On the far right, that is the most recent 12 months utilization. So like what we're looking at on the screen right now, for example, in that RX claims, most recent utilization for the City of Los Angeles in green is $62.10. The next dot to the left would represent the data or the utilization that was present at the 2025 renewal or the most recent renewal. And then for each dot going forward to the left, we're looking at utilization for the previous renewal. So it goes 2025, 2024, 2023, 2022, and 2021. So when we're looking at really kind of all of the charts together, what we can kind of tell is that on a year-over-year basis, the gap between the City of Los Angeles and the health plan is fairly on par, with the exception of for outpatient claims in the 2023 renewal, we saw a little bit of a spread from what we saw from that 173 to the 239. So we saw a little bit of a separation between the city and the health plan, but that has maintained over the past few years. So that's good for kind of estimating where more kind of on par with our average rate increases going forward. Then the last piece was within the inpatient side. We do see a bit of fluctuation as we go through the years in terms of not just the spread between the city and the health plan, but also just kind of on a year-over-year basis, increases and decreases can fluctuate quite a bit. And this is something that we kind of expect to see on a single group basis, as a lot of this utilization is going to be attached to things like high cost claimants. So as we see new ones come on, utilization might increase, and as they fall off, we'll see it kind of drop. But this is just kind of the high level overview for the primary categories. On the next page, what we'll take a look at is the top utilization categories for inpatient, outpatient, and pharmacy. Within the inpatient, the very top one that we have, certain conditions originating in the perinatal period. This is where we saw the largest percent and dollar increase within the inpatient setting for the city of Los Angeles. What kind of drove this increase? We had an increase in the number of premature deliveries, which required ongoing medical assistance post-delivery. We saw specifically two more extreme immaturity or undeveloped deliveries, which equated to about $700,000 in additional claims from what we saw in the prior year. If we look at the very bottom one, the diseases within the circulatory system, overall, we saw an increase of about 8% in the number of admissions that were related to the circulatory system, and an increase in some procedures that were a bit more intensive than what we saw in the previous year. Looking at those kind of more intense procedures, we had two more additional aortic aneurysms, which equated to, on a dollar PM basis or per member per month basis, about $1 for the city. We had 6 additional people come in with conditions related to coronary atherosclerosis, which required inpatient stays, which added about another $1 per member per month to that category as well. And while there are a number of areas of increase in terms of the circulatory system, when we look at things like acute myocardial infarction, hypertension, and cardiac dysrhythmias for the city specifically, while we saw the same number of cases on a year-over-year basis, we actually saw the cost of admit for those kinds of cases decrease. So that helps kind of limit the overall increase that we're seeing within the circulatory system. And then lastly, in the inpatient side, I do want to call out that injury, poisoning, and certain other consequences of external causes, we have a pretty significant drop from the 18.84 to the 13.02 of current. And that is related to a drop off in the most recent 12 months, we lost one of the traumatic brain injury claims that was present in the 2025 renewal. And just for clarification, that's just saying that within the most recent 12 months, the paid claims for that individual are just no longer present. So it was all taken accounted for in the previous renewal. And we don't see that one going forward. So that's what we have in terms of the inpatient. When we scroll over to the right, we have outpatient. So for the outpatient, what we're seeing on kind of a across the board basis, going from that light blue of the 2025 renewal to the dark blue of the most current PMPM, we're seeing a pretty similar trend for the city of Los Angeles that we see with the health plan, kind of increases across the board. And a good majority of this is going to be related to things that we had taken into account for during the 2024 renewal cycle, where we were anticipating increased cost of services, kind of increased just essentially cost of running the healthcare system. And this is kind of that impact of those inflationary pressures that we're seeing across the board. There are, of course, changes in utilization within the outpatient category, but it doesn't really highlight it well within this page. So I saved a couple additional notes for us when we get to the outpatient detail slide. And then lastly, what we have is the pharmacy section on the far right. Kind of the two that kind of jumped out as the biggest changes were the anti-infective agents and endocrine. Within endocrine, we're of course continuing to see increased utilization of GLP-1 medications, which is a heavy pressure within that category. And then the anti-infective agents, I have a couple of notes later on in the later slide, but essentially what we're seeing here is where we saw the end of the cost mandates for COVID medications, specific COVID medications, and the cost for those medications increased very significantly from last year to the current state. So I'll discuss that a little bit further, and you'll get to see the impact on specific categories when we get to the pharmacy page later on.
I have a question on that one, actually. Looking at the trend on the endocrine, specifically the GLP-1s, given the change in Kaiser's coverage of that for 2025, do we expect that to decrease going forward?
Just for some clarity, for the change for GLP-1s as of January 1, 2025, It only affects those who were taking GLP-1s for weight loss
Mhm.
only. For those who were taking it for comorbidities such as
Right.
diabetes and so forth, there's no change in that.
Right. But presumably it does impact some group of people who were taking it.
There were only about 170 people out of the city that were taking it for weight loss only. All the
Okay.
rest were for comorbidities.
Okay, thank you.
Thank you both. And we can go ahead and move along to the next slide. On this page, we're looking at inpatient in a little bit more detail. So like I was saying before, inpatient overall increased 2%, which is lower than what we're seeing within the health plan of 5.7%. The two categories which are trending faster than the health plan, which is specifically looking at that group to health plan variance on the right side of the green charts, we're seeing the two categories being medical and mental health. Within medical, admits per thousand increased 3.5% in comparison to the health plan that saw a 1% decrease. And the dollar per admit increased 3.7%, which a large portion of this is related to essentially newborn delivery claims. We saw about a $4 per member per month increase attached to newborns and neonates. So I want to kind of create some clarification here. When we're looking at things like ongoing care related to deliveries, so like the inpatient stay for NICUs and situations like that, that would fall under the medical category. That maternity section that you see kind of in the center of the chart, that's going to be related to the cost of the delivery itself, not the ongoing care that happens after. So I just want to kind of create that clarification there in terms of how newborns and neonates could be affecting the medical category. In terms of mental health, the number of admits actually decreased 3.7% from last year, but we did see a couple of, to kind of put it vaguely, it would be non-depressive disorder stays, which required fairly significant hands-on observation and interaction. And I apologize for the vagueness within that. It's just because the frequency that we see inpatient mental health be used is so infrequent that further information becomes pretty close to identifiable information for those individuals. And there's a couple, something that I do want to note in terms of both mental health, substance abuse, and skilled nursing facility. Because those three categories are utilized at such a low rate, as in the number of individuals that utilize that category is very low. When we see a change of, like, for example, with the mental health, just a longer amount of time that that individual is within the inpatient facility and the cost associated to that individual, we see a pretty significant shift in that category for the group overall, just because the change, if it's only one person that has an increased stay, but that was 25% of the total admits, it's going to have a pretty significant percentage change within there. Okay, outside of inpatient, we'll move over to the outpatient slide next. So outpatient overall increased 10.9% compared to the health plan at 12.2. Taking a look at the subcategories, where I saw the largest changes or the largest increases were OP visits or outpatient visits up in the top left, mental health, and radiology. In terms of the outpatient visits or OP visits, we had just about a 1% increase in the number of visits, which equates to about 5,000 more per year, just within that category alone. The change that within OP visits, we saw a change from really kind of more what you would consider standard visits with your primary care physician, things like those preventative visits. We saw a shift from numbers of within there into kind of more specialized visits, specifically the genitourinary visits. We saw increased 11%, and endocrine-related visits increased 15%. We do expect, actually, we kind of expected, and we have been seeing across the board for other groups as well, endocrine-related visits increasing, just because as obviously we have more and more individuals that are utilizing GLP-1 medications, or they're coming in and getting diabetes, pre-diabetes testing, and getting results showing that that they are pre-diabetic, we have higher instances and higher rates of visits that are related to that kind of endocrine category. So that was something that we kind of expected to see. When we're looking at mental health within the outpatient setting, we are seeing about an 8% increase in the number of mental health related visits compared to the prior year. The largest increase within that subcategory is coming from neurodevelopmental disorders, where we saw about a 25% increase. Looking at just neurodevelopmental, that 25% increase in visits equated to about a $2 per member per month impact for the city overall. When we look at those more kind of thought of as the more standard visits in the mental health space, those anxiety, fear, and depressive disorders, when we compared to the 2025 renewal period to now, we saw essentially flat change in visits. So not too much of an increase or decrease since then. And then within radiology, we had an increase of about 4% more scans compared to the prior year. And then the largest increases of visits within the radiology sector were related to cancers, that kind of overall injury, poisoning, consequences of external causes, or kind of like external injuries, and then the musculoskeletal system. And then there's one thing that I do want to call out within the outpatient category overall. One thing that helped keep the overall increase for the city below the health plan was the continuation of one of our large claimants from last year to this year. This is a $3.1 million claim that is fully found within the outpatient setting, because essentially the total number of claims associated to this individual from last year to this year has remained unchanged, because such a large portion of the outpatient utilization staying flat, that helped kind of limit the overall increase for outpatient for the city. And we will see this claimant called out on the high cost claimant page later on as well.
I have a question before you move on to the
Yeah.
next. So a partial hospitalization plan program, would that fall under outpatient or inpatient for mental health?
So for anything, if it would fall into the inpatient setting, it would have to require an overnight stay. If this is a in and out within the same day, then it would fall within the outpatient setting.
Thanks.
Go ahead and move to the next slide, please. Thank you. So pharmacy, a couple of notes here. So generic prescriptions for the city is at 92% of all prescriptions being filled. This is on par with the health plan, where we see 92.7%. Looking at brand, we're seeing the largest per member per month increase kind of within that category. And this is attached to both the increased GLP-1 utilization as well as increased pricing for COVID medications. There were a couple that kind of stood out as kind of the key ones there. And the COVID medication piece has a separate connection within the chart that we're looking at on the left as well. If you bring your eyes down to that RX dollar per script within the brand non-formulary section, you'll see that the percent change is at 61.2%. And this is an impact of kind of two pieces. So in the previous years, with mandates associated to COVID medications, COVID vaccinations, things like that, we saw utilization for those drugs within the brand non-formulary category. As we've come out and those mandates have ended, we've moved COVID medications and vaccinations into the brand formulary section. And this has kind of a twofold piece, or twofold kind of effect. So obviously, we have additional movement over into the brand brand formulary category, but the biggest impact within this is things like specifically like Paxlovid that was being utilized by the city at a pretty healthy rate. Paxlovid made up about 25% of all medications within the brand non-formulary category. And in the previous years, this was about a $15 a script medication. So when we move those out of the non-formulary into the formulary category, having such a low-cost medication come out and at such a high utilization creates a pretty significant swing within that category. Secondly, we're not seeing the significant decrease in the cost of the dollar per script for the brand formulary category as we move those COVID medications in there. And that's because of the pricing of these drugs changing. There were government mandates in place that required the cost of these medications to be set at a certain rate. Since those have ended, we've seen, depending on the drug that we're looking at, costs have gone from about $15 a script to about $1,000 a script. So that's why we're not seeing the significant push down within the brand formulary category that we saw as a push up on the non-formulary category. And then after pulling those medications, kind of moving those medications from the non-formulary to the formulary category, we are still seeing an overall brand non-formulary increase on a dollar per member per month basis. And this is due to increased utilization of a specific hemophilia drug, Altuvio. From last year to this year, we're at about a $550,000 increase in utilization for that medication alone. This medication is obviously specific to hemophilia, and you'll see on the high cost claimant page later on, I'll call out where this utilization kind of falls into. On the next page, we have some additional information in terms of overall pharmacy utilization. So on the top, what we have is the top 10 drugs by net claims. So this isn't looking at any kind of specific dosage for medications. This is just looking at the specific drug and how often or how much it has been utilized in the past 12 months. Ozempic is the #1 medication for the city of Los Angeles at this time at about $3.3 million. Altuvio, that's that hemophilia drug that I just recently mentioned. Altuvio has moved up faster than any other drug when we compare from the 2025 to the current state. Ozempic remains at the #1 spot at this point in time. Down below, we have specific utilization information around GLP-1s. So what I've done for you all here is I've created a chart that breaks down each GLP-1 medication being utilized by the city at this point in time. And I break it into three main categories. We have current, which is right in the center of the screen right now. In the center of the chart, we have the utilization present at the 2025 renewal. And then on the very right, we have the net change from 2025 to current. With Ozempic being kind of the largest drug there, what we've seen as an increase from 2025 renewal to current is about a $1.8 million increase overall, or on a per member per month basis, about $4.27. Looking at GLP-1 utilization or GLP-1 drugs overall, a couple kind of key things to kind of note. Obviously, we have additional unique members of about 659. That is both employees and their spouses or dependents. And then the scripts have increased by about 2,700. And then the last piece being that price per script from 2025 renewal to current, we have seen come down for the vast majority of GLP-1 medications. Looking at obviously the largest medication being used, Ozempic, we've seen that medication on a per script basis come down almost $50 over the last 8 months. And this is related to kind of really two key factors. One, manufacturers have been able to kind of expand their production and help kind of limit some of the bottlenecking that we have seen in the prior years. In addition, with Kaiser Permanente being such a large drug purchaser within the United States, with us buying in such large bulks, we have been able to kind of get some more competitive in pricing in terms of not just GLP-1 medications, but overall medications. And the last page that I have for you all is looking at the high cost. Oh, yeah.
Sorry, can we go back to that one? I've complex question, I think, a multi-part. One simple, the scripts are much higher than the unique members, so presumably each member has multiple prescriptions for this. Is that, am I understanding that?
That's correct. The best way that I kind of look at this is if you have an allergy medication that you refill every month, that would look like on this one unique member with 12 scripts.
Okay. Okay. So in some sense, in some sense, that's a positive thing then, because we're not seeing, if I'm reading this right, that means we're not seeing people take it for 12 months. We're seeing a lower, what am I trying to say?
Kind of like where you're kind of going is we're not seeing it be utilized for every single member, every single month, every single year kind of a situation. But we do see people, and I unfortunately can't speak necessarily to our prescribing practices, but obviously there's a strict protocol, not just for individuals going on and utilizing certain GLP-1 medications, but there are also protocols in place that if they are not effective for that individual, that we start a de-prescription pattern and look for a different medication that might be beneficial to them. So while we have individuals that might be utilizing it on a monthly basis going forward, we have individuals who we're seeing it not be effective and looking for a medication that might be best for them.
Okay.
And also, it's just some additional clarity
Yeah.
for anyone who uses mail order. That would be one prescription for 100 days.
Okay.
Well, that's good call, Michelle.
So if they utilize mail order, then they get 3 months and it's not per month. So they would get 3 months supply and it's only one.
Yeah, that's right, Michelle. So people on Ozempic or some of those GLP-1s, they likely are taking this on a monthly basis throughout the course of the year. They'll probably be on this, if not for the duration, for several years at minimum. So it's not they're not taking it every month. It's more, like Michelle said, it's based on how they're filling their prescriptions and the pharmacy benefits that you all have in place.
Okay. Is there any way to see that better in the data to understand? Because I think it's helpful to know how people are taking it if it is an every month thing. And I think
I mean, like how many
it's-
people are doing retail versus mail order?
Yeah, because when we're looking at this and then, we're comparing this with other pharmacy things, other drugs and other things. And when we're looking at it in terms of this many prescriptions for this many people, if sometimes that means per month and sometimes it means per quarter, then we're comparing different things. Am I, okay?
Yeah, I
was
do
trying to be clear.
understand.
Okay, so if there's some way to kind of true that up so that we're
Let me
looking
see
at the same thing all the
Let me see what I
time?
can find out in regards to if
Okay.
you have any type of reporting retail versus mail order.
Okay, thank you. Yeah, I think that would be helpful because it's a little bit difficult, I think, then to kind of tease it out of this data if could be one thing or could be another. So it's hard to read it then.
Yeah, and there's a dollar incentive when people have mail order. It's a smaller copay. So there's definitely an incentive for those who have a maintenance drug to
Yeah.
have a mail order because it's a smaller out-of-pocket cost.
Yeah.
Yeah, and I think typically for GLP-1s or semaglutides, it's a weekly injection typically. So they're probably picking it up at least, one script per month, if not some level of mail order that gives them multiple months of injections at a time. So it'll just kind of depend on the pharmacy benefits in place and how best we disperse these. I know for some of our more expensive drugs, even though you may have a 3-month mail order incentive, sometimes we disperse them on a monthly basis. That way things don't go to waste if they are for whatever reason, switch to another medication or otherwise. So the numbers can be a little confusing. We'll see how we can dig into that to give it a more apples and apples for you.
Okay, thank you. And then with the people, you mentioned that people take it for many years, likely. So how does that affect, is there, I don't know what the word is, but is there a way to transition people off of it for that, for example, for the 170 people for whom it's no longer covered? Are they transitioned off or what is that?
So that all depends on the individual. And I need to clarify from before.
Okay.
It is still covered for weight loss after January 1, 2025, if you have a BMI of 40 and over.
Right.
So if you have a BMI of 40 and over and you were taking it for weight loss, it's continuing. Now, for those individuals who were on a GLP-1 prior to January 1, 2025, and had a BMI of over 40 and were taking it for weight loss, they're going to allow that individual to stay on it for 24 months and then relook at the situation. So everything is a case by case based on each person's medical needs. For those individuals who weight loss medications, GLP-1s, I'd have to do a little bit more digging for you because each scenario may have been different. Someone may have just gotten the prescription but not filled it yet. Or depending on, they may have been on a trial for a GLP-1. So I'd have to see what the extenuating circumstances with that are. Because even if someone goes below a BMI of 40 and they're on a GLP-1, they're still going to maintain that 24-month period for reevaluation. Now, there are also going to be those individuals who stay on it for 24 months and are still over a 40 BMI. And so maybe that GLP-1 or GLP-1s aren't working for that individual. So then the treatment plan has to be changed as well. So there's always medical intervention based on the need of the member. So I know that's kind of a big answer for a small question, but a lot of it just depends on what the member needs and what their qualifying events are.
Okay. Thank you.
You're welcome.
A small other question. What is eating disorder therapy and how is it related to
Eating
the
disorder
GLP-1s?
therapy can also be binge eating. So I know when people see eating disorder, automatically it goes to the other side, to anorexia and bulimia and so forth. But there's also binge eating and then obesity eating on eating disorders as well.
Okay. So then this is used as presumably as part of an overall
Overall
treatment plan. Okay. And it's a smaller proportion, obviously. It's just a few
Correct.
people.
For the eating disorders, it has no affiliation to a chronic condition such as diabetes or hypertension and so forth. It's truly an eating disorder.
Okay. Gotcha. Okay. Thank you.
You're welcome.
And then the very last slide that I have for you all today, for me to review, is the high cost claimant slide. So a couple of notes here. So these are claims for the city of Los Angeles that are over $900,000 that both took place and were paid in a 12-month period. In additional, and on the top, we're looking at the current utilization, and on the bottom, we're looking at the utilization for the 2025 renewal. Another important call out is that we have that primary diagnosis label that's at the top. This is kind of important to understand how this identifier is created. So that label is not always going to be the primary condition that's generating the large claim for the individual, but is the largest single claim instance for that person that has a diagnosis attached to it. This is very apparent when we would look at individuals on the current year for number 2 and number 4, and I'll go into a little bit more detail for those two. But kind of going down the list on the current year. So person number 1, they are a continued claim from last year. This is the $3.1 million claimant within that outpatient setting that I alluded to prior. It is a metabolic condition that requires bi-weekly treatments, where each treatment costs about $165,000 per visit. Person number 2, so this is one that I was saying the primary diagnosis does not represent the condition being treated for that $1.45 million, because of course sleep apnea is not going to cost that. This is actually our hemophilia patient. And it doesn't show up as a hemophilia diagnosis because within the last 12 months, the care essentially for the hemophilia has been 100% prescription based. So the drugs that they're on do not generate a diagnosis. Person number 3 is a hemorrhage within the brain that required surgery and extended inpatient stay. Person number 4 is the second person. Kind of that diagnosis doesn't represent what's going on here. The individual is admitted with a few major issues, sepsis being a result of kidney failure. But the bulk of their utilization was attached to circulatory and specifically heart surgeries. And then person number 5, this was a traumatic accident. We'll put it as it was a traumatic injury that required a significant inpatient skilled nursing facility and ongoing outpatient care. So I think I'll pause here to see if there are additional questions for either myself, Michelle, or the rest of the team.
Just to add a little clarity on the first one, because I saw a lot of heads turn on the 3.1 million. Niemann-Pick disease, that's a rare genetic disorder that causes a buildup of fat and cholesterol cells, which can also lead to cell death. So it's a genetic disorder.
Thank you for the clarification, Michelle.
I know that we've given you a lot of information in the last 15 minutes, going from overall claims, inpatient, outpatient claims, as well as pharmaceuticals and your high cost claimants. Now, with your high cost claimants, typically in the past, the question has come up, how does wellness come in and so forth. There are some conditions where it's a genetic disorder, wellness is not going to make a difference. Now, but items such as kidney disease and heart disease, yes, nutrition and exercise and overall health can be a game changer for those individuals. So through the last couple of years, the city of Los Angeles has partnered with Kaiser Permanente via webinars, virtual challenges. There's been a wide variety of different wellness programs, and the LA Well Department right now is working with Kaiser Permanente for the 2025 wellness programs as we go forward. Are there any questions on any of the slides that we presented today? Yes.
So for the high cost, person number 2, it says both adult and pediatric. Is that a typo?
No, that's what that diagnosis is. It covers both adult and pediatric. So that individual, even though it has sleep apnea, as Mark indicated, it's not their primary condition. The primary condition is hemophilia. They just happen to have a very high cost claimant that was apparent associated with sleep apnea, but they're actually a hemophiliac. That's their core disorder.
I have a question or maybe a comment. Based on your last comment, fully understand what you're saying about genetic versus, preventable conditions and the wellness program. But I think the issue that we're having is bridging the two, right? I mean, you see the GLP-1 utilization going up, I guess, right? And you're saying it's covered for weight loss as well?
For those who have over 40,
right?
Now, for those individuals who have diabetes, chronic conditions, before someone goes automatically into a GLP-1, they do have to kind of go into a step program because GLP-1s are not for everyone. There could be side effects. It may not be right for their treatment plan. So they start off with oral medications. If more oral medications don't work, then they'll try a variety of different GLP-1s to make sure that individual has the right medication.
Right. But I guess for these preventable, diet, exercise type conditions, I mean, how do we, and it's not for you to answer here again, but again, bridging that gap instead of you're going toward the medications, which also just drives up the cost, right? How do we bridge that and get a wellness program that really can positively affect?
Now, there's definitely where the city can provide all kinds of programming from nutrition to exercise, but the individual also has to have a personal aha moment that says, I want to change my lifestyle. I want to change my eating habits. I want to change my exercise. I want to do something that's for me. Now, that may take a couple months. It may take a couple years. It really has to do with getting the person at the right time. Now, having a wide variety scope of different programs may hit that individual at the right time that says, gosh, I think I can participate in that virtual challenge and see what my eating's like and so forth.
Short of them hearing about it from the city,
Mhm.
I mean, is Kaiser and or Anthem doctors, are they aware? And, you know, and I know there may be not as much programming available as we'd like to combat some of these things, but I mean, is there a connect there? Is there a disconnect?
You know, there is I can only speak to Kaiser Permanente. There is definitely a connect if your weight and your lifestyle is impeding, you know, the way you live.
Like encouraging the use of the wellness program.
Encouraging wellness programs such as Kaiser Permanente has also wellness coaching, which is at no cost. There are nutritional programs, weight loss programs that are at no cost. There are also programs that do have like food items that do come at a cost. So there's a wide variety of programs. I like to say it works. I didn't use any GLP-1s, but I started Kaiser Permanente's program about 4 years ago and I lost 70 pounds. And it was, I hate to say it, it was probably like the 7th conversation my primary doctor had with me saying, hey, you might want to look at your lifestyle. Very kind. But it wasn't until the last conversation was, our next conversation will have to be about diabetes if we don't do something. And it was that aha moment for me that said, okay, I really need to look at this. And that's when I started a wellness coach. And that wellness coach, you know, the wellness coaches talk to each person where they're at in their life stage. Whether, okay,
Is that available to every Kaiser member?
every Kaiser member at no cost.
So these are things that we need to be advertising for.
Absolutely.
Also,
Absolutely.
if you look at the medication, it's also preventing those individuals from going to something more complicated, more difficult, more expensive, could be on that list. And sometimes you have to look at what you're paying for the medication to offset what 3 million or 1 million, whatever. But to be honest, some people you're going to change, some people you're not.
Yeah.
And the whole purpose of some of the medication is to offset that, because if you don't, you're going to get those very, very high
No,
claims
absolutely.
into heart attacks and whatever. Sometimes you just have to balance it off, because I can guarantee you everybody's not going to change. You just got to because a shot or whatever might be easier for them to deal with versus, doing that is just, it's.
No, and it's definitely, that's where the relationship comes in with the member and their doctor. The doctor can suggest, but someone has to be willing to go that route.
Do any employers offer incentives for going that route?
No,
Is that something that can be explored?
not medically. You can't give an incentive to take a drug.
No, to do the opposite.
Oh, incentive to give them a drug, sorry.
To better their health instead of just.
Well, before you can even go on a GLP-1, you do have to be admitted into Kaiser's healthy lifestyle program. So that is a prerequisite.
Mm.
Now, can I say everyone takes it seriously and changes their diet? They may go to class, but I don't know what they do at home.
Yeah, and I just wanted to chime in. I think it was, I'm listening virtually, I think it was Tony talking about kind of the trade-offs and the cost versus treatment. Semaglutides and GLP-1s are still relatively new to being prescribed. And I think what we're going to be interested in looking at from a clinical perspective over time is what is that ROI? So if you're looking at a high population of diabetic patients, how much avoidable ER admissions or visits are we preventing because members are staying on top of it? How much from an amputation perspective are we able to avoid in terms of cost because folks are taking a medication that is very efficacious, that it's working to help control and monitor their specific chronic condition. And so I think as we look at this specific class of drugs over time, we'll be able to put together studies, and even some of our reports will show, how much are the ER visits changing in that specific population of a class. The FDA, I think it was the end of December, just approved GLP-1 utilization for obstructive sleep apnea. So that'll be under evaluation to see if that's medically the right way to start beginning treatments in some of those challenging cases. So there's a lot of new uses that we'll see coming out specifically to GLP-1s, but a lot of those things can be prevented by lifestyle. And so Marlene, I think that's a great point of the conversation is, what do we do before we get a member onto a GLP-1, which we know is costly? We know they work, that's great, but are there other things, to Michelle's point, that we can influence over time? And so that's really where a lot of our specialists are looking at, our weight management folks, diabetes specialists. how do we get folks to take lifestyle serious in order to prevent them from having to go on an expensive drug as the only solution? Because we know once they come off the drug, they tend to revert back to where they were, sometimes even putting on more weight or reverting into a more severe state of that chronic condition. So all important things to think about. And I think as time goes on, the research will show how effective GLP-1s really are for the long-term management of these various conditions.
Thank you, Justin. And yeah, as Justin indicated, we'll be able to have more statistical reports because a lot of this is brand new, the GLP-1. So as we go on into the future, we'll be able to have more statistical reports as time goes by.
Thank you.
You're welcome.
How, speaking to that, like when I was looking at the chronic conditions report later in the appendix, you know, I'm seeing the increase in the use of these drugs, but then there's no concomitant decrease in the prevalence of these conditions that it's supposed to be treating. And so there's an increase in diabetes, there's no change in obesity. So what is the length of time between, you know, we're prescribing all these drugs and we see the effects that they're supposed to be causing? When does that show up in the data? Because I'm not seeing it now. And if we're using these ostensibly originally for diabetes and the increase is going way, way up, then it's confusing to me that I'm also seeing diabetes still also increase significantly.
And they can also be new people who are diagnosed that haven't been given any medication either, that are just in the beginning of their journey being a diabetic. So the percentages that are going up, the numbers that are going up may also be new individuals. Now, for the city of Los Angeles, the obesity rate has stayed flat, but it's still at 42% obesity. So that's a very large number out of the Kaiser population to be in the obesity category. So you've got new individuals, you've got individuals that perhaps are just in the beginning of their journey, or they could be 24 months in and just haven't had any personal change.
Yeah, and I think the other part of that conversation, and, you know, respectfully, I'm not a clinician, so take this with a little bit of a grain of salt, but, you know, type 2 diabetes is preventable, type 1 is not. So type 1 diabetes, it's more about the management of adverse conditions or reactions for the type 1 diabetic patients. And so how are we managing that? How are GLP-1 drugs actually managing and keeping them in a managed state versus, again, going back to avoidable ER visits, amputations, et cetera? Whereas type 2 diabetes is preventable. And so how do we use lifestyle change to help hopefully influence people from moving into a category of obesity that we know could potentially lead into type 2 diabetes? So it's kind of really thinking about that full spectrum of a person's life. If they're not thinking about lifestyle, you may see them move into the pre-diabetic phase. You may see them move into type 2 diabetes. You may see them move into class 1, 2, or 3 obesity. So it's really thinking about that full spectrum of a person's life and when do you start that level of intervention. I'd like to think that our clinicians have these conversations fairly regularly as they're seeing folks move up. I know personally when I was going through the COVID period and I'd see my physician, you know, there were conversations about my BMI is continuing to increase. What are we doing from a lifestyle perspective? But that's also your employees spend a lot of time at the employer site. And so where does employer programming kind of meet that intersection of helping influence a person's lifestyle decisions and behaviors?
Thank you.
Any additional questions?
Actually, I have another question on a different topic. On the lifestyle risks overview, there was smoking rates have gone down, and I just was curious: are those based on self-reported measures?
It's when you're being checked into a visit, and if someone's
And
a
they ask that
smoker, they'll say, are you still smoking?
Okay.
So it's typically in the check-in process.
Okay, and then how do we know then if vaping is included in that? Because I know some people think, oh, I'm not smoking, I'm using a vape, and they don't think of that as the same thing. So is that not to be considered part of that? Is that supposed to be
No,
not
that's a great
included?
question. Let me ask if
Okay.
we're delineating, if we're asking, hey, are you still smoking or vaping?
Okay,
So let me ask about that one.
thank you.
Yeah, if I remember a current visit of my own personally recently, it's lumped in the same. They ask if you smoke and or vape, but we can clarify just to make sure that's
Okay, thank you, I appreciate that. Just a small thing. There's a few of the charts starting at 31, and then there's a few of them like this. But there's in the bottom left, for example, on 31, we're at 79%, and the little box there says of screened adult members, et cetera, and it ends with that's. That's what. I feel it looks like it's cut off, unless I'm misreading it, but it looks like it's cut off. And there was a few slides that were like that.
Okay, I can go back and make sure anything that's cut off is resent.
Thank you, thank you. I think I had one last one on 35, when we're talking about the blood pressure. I got confused on this because the top right narrative is nearly half of US adults have high blood pressure. But then I'm looking at the chart and it's not, it looks like 10%. So I feel like I'm missing something when I'm reading this.
That the right statement is just an overall statement, just about US overall, not necessarily depicting on the city of Los Angeles.
Okay, well, but that seems strange if US in general has nearly 50% high blood pressure and the city of Los Angeles somehow has 10%.
Yeah, I mean, the way I would
confusing
think
to me,
about
'cause
it
that
is,
sounds-
I would also kind of correlate it if you look at a chart of the BMIs, average BMI across the country. You'll often see that somewhere in the Midwest and the South, they tend to have a much higher BMI than they do, say, on the West Coast. And so, you know, that's a pretty large chunk of population. It probably, my guess would be it has something to do with that. We tend to be a little bit healthier on the West Coast than we do in some of the Midwest and the Southern states. So it's probably correlated to kind of the population mix of the country and where the majority of those that may have a higher BMI and ultimately a higher blood pressure or cholesterol would reside.
It just seems like a really big discrepancy. So that was what kind of caught my eye, is that that's such a big gap. I didn't think we're that much. Especially given our traffic, I didn't think our blood pressure was that much lower than other places. That's so for me, I was like, I don't know about that. So that's why I was confused about that. That's all I had. Did anybody else have any other?
Any other questions?
Okay, thank you so much. I know
Thank
it
you
was
for your
a lot.
time.
Thank you. All right, so moving on, item number 6, we have a presentation from Keenan on RFP education.
So this is in response to last meeting. We did bring the medical RFP forward, and we had discussed at the meeting we would have some education sessions over the next few JLMBC meetings. So Keenan's going to start the presentation. I'm looking for, and Keenan's looking for kind of your feedback. Well, is this presentation going to hit the mark that you guys need for education? Do you want something different? Do you want something more? So think about that as we're going through.
So what we're kind of hoping to get out of this, just like Paul mentioned, is, definitely get you up to speed on the different elements that go into rating the plans, the different kinds of plans. Sorry, am I not loud enough? Yeah. And so when we are going through the process and we're making recommendations to this committee that, everybody has a very good understanding of the different pieces that come together in the process. So we're going to, today's training is going to be focused on the plan market overview, like the different carriers that are out there and their market share, the health plan types. So, we're considering a couple of different plans for the 2026 plan year. So we want to make sure that you have a good understanding of those options. And then education considerations for the employee base. So just like we were talking about how we really need to get the word out on the different things within the health plan that people can take advantage of. We have some considerations for you as well. So the objectives, just like we mentioned, are really just to expand the knowledge of this group. So we all feel comfortable when we're going through the recommendation process for the 2026 medical plan. And then identifying any areas that might be something that we could focus on in other meetings or in terms of employee education moving forward. So we've kind of broken it out. So over the next 4 months, we're going to be having something similar in each of our JLMBC meetings. So this month, we're going to focus on the health plan design. February, we're going to do a continuation of that and kind of get more into talking about networks and that kind of thing. In March, we're going to break down underwriting. So what goes into developing all of the rates and how the carriers calculate their renewals. And then in April, we'll finish off with the different funding options. So right now, the city is fully insured. We've talked briefly in other meetings about being self-insured and what that looks like and other type of funding vehicles. So that's our training schedule. If something else comes out of these meetings that we want to focus on, we would love to do that as well.
Hi, Gordon Darm with Kenan. That was Telegraph. She didn't introduce. I'm going to talk about the kind of market conditions of the carriers in general. And this is really, really important in the RFP process. Not only in the RFP, but also in the renewal process. Typically, carriers have 2 different cycles. It's market share and then profitability, or sustaining their market, their book of business and so forth. And so oftentimes as we evaluate and we present to you the RFPs, what's going to be really, really important is that what we don't want to have happen is someone who is aggressively seeking to increase market share, do it at extremely favorable rates that perhaps may not be sustainable on a long period of time. What that then means is in the following years on the renewals, we would be here presenting to you higher increases. That's going to get you upset, and that's going to give us high blood pressure. It's about making sure that we recognize what each carrier is bringing to us, the type of rates, the type of plan designs, as well as how it's balanced. Therefore, when we put the RFP out there, we not only look for what's the best rate and price for next year, but also what kind of rate caps, what kind of guarantees will they give us for future years as well too. Both of those become very, very important. This slide kind of gives the next 4 slides all in one slide altogether, but I like pictures. So if we could go to the next one. This is kind of market share as it currently exists among the carriers. And it's divided into 3 separate markets. There's the individual market, which would be like covered California and individuals going to, not the city. Then there's small group, which is employers less than 100 employees. Also, again, not the city. So the one that really applies is the large group market, where we see about 9.5 million people covered in the state of California, of which I've over the holidays I was told by my grandchildren I don't know the difference in some of my colors. I think it comes with aging. The Kaiser is the largest. I believe that's orange. Correct me if I'm wrong.
It's orange.
Okay. Followed by 13% by Elevance, which is, as you know, Anthem. Blue Shield at 9%, United Healthcare 7%, CVS Aetna, which, if you don't know, several years ago merged together at 4%, Cigna at 3%, Centene, which is HealthNet at 3% as well. And then there's a lot of regional players. If you add them all together, it's about 4% market share. We look to be hopeful that obviously all those with the larger market shares, that they will respond to your RFP, and we make it, of course, available to anybody who'd like to, and it's up to them to make sure they qualify as outlined by the RFP. Okay, and then the next slide really is just a position of change. And also if you really want to look how that 9.5 came together, who has what as far as number of members and so forth. So the one thing it does introduce on this slide too is at the top, there's two acronyms, and we love our acronyms, DMHC and CDI. The CDI is the California Department of Insurance, and the DHC is the Department of Managed Healthcare. So Department of Managed Healthcare is more over the HMOs, and the CDI is over the PPOs. It's kind of higher, more completely. So we'll go on to the next slide. And DMHC and CDI are the two regulators for that, and you kind of see the breakout as well too over the years, how the plans have grown as well. One of the things in the RFP that's going to be very, very important, and we have seen, this goes back to 2010, where loss ratios were introduced as part of the ACA that, hey, you can't have a retention load that is too large. And by that, what we mean is of every dollar that you pay in premium, it's about a 15% can be used for administrative purposes for everything else to administer the plan. 85% of that should go to, or 85 cents on the dollar needs to go to paying claims and so forth. And so you kind of see here, we do have at the top of the screen, 17.6% with Health Net, which would be an outlier, meaning they're greater than 15%. And then you see the others underneath what their expense load is. When we go through the RFP process for you, we will be looking extremely close at what their admin fees, what their loads are, and so forth, so that we can use that as one indicator of maximizing those conditions as well too.
So do PBMs, is that part of the ratio? Or
these are insurers. PBMs are pharmacy benefit managers. PBMs is more of a self-funded concept. In the insured market, it's usually the carrier is the PBM as well too. So from this perspective, when we're looking at carriers, pharmacy would be included in there as well. And then on the next slide, we're looking at, this is for administrative services only. So that would be in a self-funded environment. Looking again at administrative service contracts there only, and size of the carriers there as well. But and we do contemplate getting PBM quotes from those that are interested on, because we are going to be requesting self-funded quotes. Not saying you're going self-funded, but at least to educate and have you look at those options as well too.
All right, so we'll move into the marketplace trends. So a lot of this, you kind of heard some of this from Kaiser, but what are we seeing that is, year over year as costs are increasing? There's a consolidation of healthcare markets. So, fewer carriers out there means, less competition. So that's impacting rates. And also corporations, CVS buying Aetna, Amazon taking over One Medical, United Health is another one. Private equity firms as well. They're acquiring individual physician practices. So that just changes the landscape of how we utilize healthcare. And then mergers between hospitals and health systems, that's also happening. So again, the less competition, the higher the prices. And provider shortages is a major issue now, where we have a huge crisis in terms of primary care physicians and other specialties. So that's making it more difficult to get into providers on a timely basis, which leads to longer wait times sometimes, and deferred care, which can exacerbate certain conditions if people aren't going in regularly. So also the specialty drugs, gene therapies, we just saw that within the Kaiser data, that $3.1 million claims is, gene therapy. And also the GLP-1s, 3.1 million was, I think, the number of what you were up to this year. So one thing that we didn't put on this list that is also important and that is actually helping bring the cost down a little bit is, the virtual care has expanded enormously since COVID and continues to. So that's actually going to help decrease costs over time.
And I think especially as you look at your work population, don't think of the old people like myself, but if you think of your younger population, if they can't do it on their phone, they basically don't want to do it. And that includes virtual visits. They want to see their doc, talk to them, and pretty much leave it. It's a changing marketplace for some. And as we look into the RFP, we really need to take that into consideration. That might be one of the areas that you'll be seeing a little bit more than you have in the past is relative to virtual care. What is available? What are you comfortable with as far as offering to your membership?
I have a question. When you mentioned that the corporations are acquiring physician practices, what's the effect on us? Like, is it a monetary effect, or is it are they grabbing up more groups so that there's more than in the marketplace, or how does that affect us?
I think in general, my initial take on it is that you're going to have different oversight, right? So we were talking about the Department of Managed Care, Managed Health Care, and the Department of Insurance. They're regulating those insurance carriers. These are individual corporations that are coming in on the private side and purchasing healthcare systems or, primary care physician groups. So it's going to change the way that we access that care. I don't know, in terms of dollars.
Yeah. So from a consolidation perspective, when these groups come, whether it's corporations or provider groups coming together, whatever it is, it's all about purchasing. And the greater number you can dictate in a particular region oftentimes leads to better conditions for the group per se and tougher negotiations. With the exception of Kaiser, because Kaiser's a different model. Their providers are employees of the healthcare system. But if you look at an Anthem, a Blue Shielders, and so forth, constantly there's negotiations going on, right? And even now, I believe Anthem with Scripps, they've been in negotiations. That's gone a little bit south on them right now. Hopefully it'll get better. But you're constantly trying to figure out what's the best deal. And they're not talking about wanting new office chairs. They're talking about we want more money for the services that we're offering. The hard part for the carriers then is what can we agree to and build into our rates without having to ask for too much of an increase, because they typically negotiate on a 2-3 year basis. Did that answer your question? Sort of.
Next slide. So I know you've probably heard a lot about all the different plans, but we're going to go through them anyway, because I think there's some merit in kind of understanding the differences, the little nuances. So, with the HMO right now, you've got 4 different HMO plans that there's no out of network coverage unless it's an emergency. You don't have an annual deductible. You usually have co-pays, not any sort of co-insurance. You do need a primary care physician, and that primary care physician is going to refer you to all levels of care. So that is the main driver of what is an HMO. You don't have to go out and get a pre-authorization for certain things like outpatient treatment or inpatient surgeries or MRIs, that kind of thing, because you have that referral from your primary care physicians already. So you don't need to do that. Advantages, your provider is doing everything for you, right? So they're submitting your claims, they're referring you to other levels of care. So you don't have to worry about that. Disadvantages on HMO is that it is a smaller network. You don't have that flexibility of going out of network if you want to see a specialist that's not in the network. So that's how your current HMOs work. There are something called deductible HMOs, and that's just the exact same thing, but adding a deductible to that. So you'd have to meet a deductible before some services would be covered. For the PPO plan, you also have a PPO plan at the city here, and you do have that option of going in and out of network whenever you want. So when you're out of network, obviously the plan covers you at a lower percentage. You have a higher deductible, so you have higher out-of-pocket costs. Copays, you don't usually have copays for most things. You do office visits, prescription drugs are typically copays, but mostly coinsurance. So you pay a percentage of the bill as opposed to, and you usually meet that deductible and then have to pay that coinsurance. So you don't have to have a primary care physician. And again, that person doesn't have to refer you. So you can go out and, I want to see an ear, nose, and throat specialist. I just go, I make my appointment and go. I don't have to have that referral. Prior authorizations are definitely needed under the PPO plan. And then the advantages are obviously that you do have that flexibility. You don't have to get referred, but the disadvantages now it's kind of the ownership of your coverage is on you. So I've got to kind of figure things out for myself. I don't have a doctor necessarily submitting all of my claims for me. Usually if they're in network, they'll do that, but out of network, you're kind of on your own. An EPO plan is not something the city has had, and that is similar to an HMO in that you don't have out-of-network coverage unless it's an emergency, but you don't have to have a primary care physician. And you don't have to get referrals from that primary care physician. It's always recommended for anybody on an EPO plan, but it doesn't necessarily have to happen. Sometimes EPOs use a larger network, so a PPO network. So it's not necessarily that you're as confined as you are within an HMO. But for that reason, it's a little more expensive, right? So it would end up, the premiums for an EPO plan are typically higher than an HMO because you do have that option to kind of self-refer. And then there's something called a POS that I haven't really seen much of. And when looking through the reports that we just went through, there was a tiny little sliver of the pie that was POS. So point of service plans are kind of a hybrid of putting an HMO and a PPO together. So there's an HMO as the first tier, and then there's the PPO in-network kind of tier, and then you have out-of-network. So it's kind of putting the two together. So
as point of service, POS stands for point of service. So it depends on where you get your care done. If you get your care done by a provider that's in the top tier or the HMO level, you get a certain benefit level. If you get it done by not somebody who's in the HMO component of it, but in the in-network PPO part, there's a different level of benefits available, and out of network is just plain out of network. So as I started my career in the 90s, very popular.
yeah, not so much.
Not so much anymore.
Well, it's kind of confused. It's a little confusing for people to understand because there are those different levels. So I would say that's one of the downsides. And then the last plan is the high deductible health plan. And we'll go into that a little more detail in the next slide. But, that's again, it's a PPO plan. You have both in and out of network and a much higher deductible. And the good news is, or the thing that most people like about a high deductible health plan, or maybe the only thing they like about a high deductible health plan, is the fact that you can pair it with a health savings account. And we'll talk about that on the next slide.
If I could just kind of share, currently the city has multiple HMO plans, but if you look at the plan design itself, all of them are extremely similar. What differentiates them is what the provider network is. You have a full HMO network, you have a narrowed network, and you have a specialized network, but the design underneath is about the same. So one of the things that really comes up is, or makes you think, is basically having that one common plan design in the best interest of the employees of the city, or should there be, basically we've got, if you put network on a horizontal basis, do we need to do a vertical integration where plan design is at different levels? This is kind of where the high deductible health plan comes in, especially as you give consideration to the fact that the average individual incurs between $1,600 and $1,900 in healthcare a year, and we're all paying the same. Now, you tell that to the person who we saw from Kaiser, who was a $3 million claimant, and they'll say, well, I'm a little above that average. And that's why we're all grouped together. But there's populations that you represent, that your younger populations that say, I'm Superman, I go get my annual physical. Outside of that, I don't see a doctor. And sometimes you're lucky if they go get their annual physical. And so their cost is substantially less. And it's really, what is it that you want to do? How do you want to represent? Because even that young Superman will someday be that old aged employee. So, I see a hand up.
Eventually get you.
So.
No, I'm the old aged employee.
So I think that's one of the things that the city and the JLMBC have to give careful consideration to as you look moving forward with the RFP, and what is it that you want to represent? I'm not saying one answer is right, one answer is wrong, but it's what the JLMBC and what the city would like to do.
But at the same time, the design will predict or determine what the cost is for the city as a whole, right?
Yeah, we'd all love the pricing of a high deductible health plan with fully comprehensive coverage, but unfortunately that doesn't exist on this plan.
Yeah, and kind of the idea with a high deductible plan, we could probably go to the next slide, is that you would save enough in premium. So the higher the deductible goes, the lower the premium, right? So you'd save enough in the premium that potentially the city could put money into the health savings account on behalf of the member. So in order to qualify to be an HSA compatible plan, the IRS has these parameters, and they are typically adjusted for inflation on an annual basis. So we've seen them tick up $50 or $100 each year. The minimum deductible for single would be $1,650, for family it'd be $3,300. This is for 2025. In the RFP, we're actually asking for limits a little higher than this because we don't want to have to make adjustments. The annual out-of-pocket limit, $8,300 for single, $1,660 for family. And then the maximum contribution that can be put in, and that could be a combination of the employer and the employee putting in money into the HSA, would be $4,300 for single and $8,550 for family, any individual covering dependents. And then there's a catch-up contribution similar to like a 401k. So if you're 55 or older, you can put in an additional $1,000 each year. So the thing about the HSA is that that's your individual account. So you take it, whether if you stay here, it just rolls over from year to year. If you retire or leave the city, that is your individual account that you take with you. And you can make changes to it throughout the year. So it's not like an FSA where once you put it in, like it's there, you could say at the very beginning, I want to put the total maximum contribution. And you could get halfway through the year and have a big expense and say, oh, I don't want that much money coming out of my paycheck. So you can back off, you could take down, take it down to zero. You can make that change throughout the year. So you have flexibility with that. You also have the opportunity to invest that money. So depending on the administrator, sometimes it's $1,000, sometimes it's $2,000 minimum. Once you have that amount in there, you can actually put it into investments, and the administrator dictates what those investments are. There's usually a large menu to choose from. And there is the triple tax saving feature, which is what most people are interested in. So when you put those contributions in, they can come out of your paycheck, and those would go into this account free of tax on a federal basis. There are some states, California being one of them, New Jersey's another, where it is subject to state tax. So you would have to report that on your taxes every year. The second part is that when you take out money to use for expenses, you're not taxed on that. And then any of those investments that you've got, if you've got any income as a result of that, that is also free of tax. So it's got the trifecta. If you are enrolled in an HSA, you cannot also be enrolled in a flexible spending account. So that's considered double dipping. So there is something called a limited purpose HSA where it's just for dental and vision. You can do that. But these accounts are for medical, dental, and vision expenses. You sign up for one, you also would get a debit card. So it makes it really easy to use. Just get in the doctor's office, you could take it into a pharmacy. So it's really convenient. Another thing
No.
on that. Any questions on HSA high deductible?
I have a question. Sorry, I actually was gonna save, I had this question already and was gonna save it, but I think right now is appropriate. And thank you for bringing this to us. On this, yeah, on these high deductible health plans, HDHP, I did read that the HSA is usually a component with it, and many times the employer is contributing to that. I mean, because from what I understand, like on this minimum single coverage, right? The employee has to spend $1,650 before insurance actually kicks in. That's first, not after, right?
Correct. So and what I should have mentioned is any plan that has this, that is deductible, right? I mean, it goes up from there. That's the minimum deductible. But all preventive care in networks covered at 100%. So if you're only going for preventive services or only taking preventive medication,
Like that annual physical?
Yeah. If you're only doing those things, you don't have to meet that deductible.
Okay.
It's covered at 100%. So the deductible would only kick in when you're doing something beyond preventive.
So something they don't expect, like they get sick.
Right.
At what point is the HSA employer contribution negotiated? Is that when for you guys? Is that us individually?
That
In
would
our
be something
Emily?
as we go through the analysis of the RFP, if we are thinking, if we're thinking about offering a high deductible health plan, then we would talk about how much, when we get the rates back, how much are we talking about that we're saving? So is there a pot of money that we could use in saved premium for the employer to put money in there? It could be that that doesn't even work out, and it, it doesn't make
The
sense.
intent of asking for the high deductible health plan that is HSA eligible is that it would be it would have to be below the city's contribution level currently, because then,
So
tell me if I speak out of turn here for the city, but I don't think the city cares. It's kind of like you want to get paid in 10s or 20s. The city's going to make the contribution requirement as outlined in the bargaining agreements. if there's a choice to take some of that money and put it into an HSA and the other to pay premium, it's the same as taking the full amount and paying for premium.
I just want to add, so right now, the authority though, the only authority the city has is to pay premium. There's not an authority to pay an additional amount past premium. And we are looking to change the authority though. That's a conversation that we've been having in this committee of changing the authority of how the subsidy works. But right now it is still written as there's only the authority to pay premium. So this would be a change that we'd still have to discuss on what the city avenue would be and how that would work. Outside of the math concept.
Yeah.
Just to clarify.
Thank you. And some of the purposes here today are, within the time restraints we have of the RFP process, the decision-making and implementation, what is the best alternative that we can do now, but also exposing you to those other alternatives that if they do require changes that might take a little bit longer, that we've at least exposed you to the concept, and then you will have time in the off season, so to speak,
Right.
to look at those items a lot more carefully.
Thank you.
So we did touch on employee education earlier and how important that is, making sure people understand what's available to them, how to use your benefits, and if there's like coaching or care coordinators or anything that we can, kind of help individuals with their well-being and the outcomes for them. We want to make sure that we're getting in front of that. And also, we should be doing this education year round. So much of it happens during open enrollment when everything's crazy, but we know that we've kind of got their attention for a minute. But especially if there is a change in the plans that are offered, we want to make sure that we're out in front of that as much as possible. There are decision support tools that can help with that help members understand what the options are. There's some modeling so you can try to figure out what your out-of-pocket costs would be under the different plans. So we want to make sure we take advantage of all of the resources out there. And then, using different modalities. So Michelle mentioned earlier that, you got to catch that person at the right time, right? And it has to be something that makes sense to them. So that, now what I see a lot of are like little short videos. Nobody wants to hear an hour presentation, but I'll watch a 5-minute video that gives me the basics, right? So videos, getting out there, pushing campaigns so that you can get a larger demographic, and even targeting different groups of people. So it could just be like, hey, we're going to focus on make sure that you have a primary care physician, make sure that you're seeing that primary care physician on an annual basis, et cetera. So, those kinds of things that if we can help people understand the benefits and how to use them better, then hopefully we can help them kind of manage their conditions and avoid those larger claims down the road. I think that is it for us. Any other questions from the group?
We should take this show on the road. There's a lot of information here. Thank you very much.
Yeah. Thank you.
Thank you.
We'll be back in February with more.
Yeah.
Thank you.
Employees might benefit from. I mean, I know why we get it, but it's also just kind of interesting as a consumer.
But Paul, you had mentioned wanting some feedback from the group on the presentation, and is it sufficient or is there different things? So what kind of a format would you like that information in? Or
it can be informal. We could talk about it now if anybody has any feedback at this moment. Did it move at the right pace? Do you want it to be faster? Do you need more detail? Do you want it to be slower? Or did it seem good for what you experienced?
what do you think?
Yeah, I thought, because like I said, I thought it was very, very informative on a number of different levels, even just on the straight consumer level was perhaps, I wasn't wearing my my committee member had, while I was listening to most of this, it was mostly a consumer-driven prism of, look through, but no, it's very, I thought the pace was fine. The information was very, very good. And if we can keep up some of this stuff, I think it'll be very helpful for us when we address larger issues.
I want to selfishly ask a question since you said that then. So on this slide, on the health plan type slide, in the RFP, we are asking for every type that's on this slide except for the POS.
Right.
So we're just saying, so everything else is out there. Do you feel you understand enough, I guess, on just types itself, to that degree, since we're going to be presenting all potentially, all the different types of up to that point?
I mean, personally, I don't think we knew that those were all the alternates that you'd be asking for. It seemed like on the RFP, it was kind of, or at least the draft one, it was kind of an open-ended question as to provide us any. So I did start doing some research on alternatives, and that's, I think, why I was maybe able to follow this a little bit more. But are these then what you're saying? Because there could be any alternatives offered, right?
Yeah, well, when we said alternatives, and I know that's kind of confusing, but when we said alternatives, we were saying alternatives of these specific types. So we're going to be
But that's
asking
not
for.
specified in the RFP, is it?
It is, but it's not clear or clearly identified. There's so many pages and so many words. So I guess that's probably why it might be confusing. But so we were asking, so to keep with PPO, for example, we're asking for them in the RFP to do a match to current, to say, tell us what the exact same plan looks like, and then give us alternatives based on that PPO. And that alternative can be in different directions, changing the deductible, changing the copay amount. It can also be changing other aspects of what this plan is structured as, kind of in this column. Am I saying completely?
And
Incorrect.
mixing and meshing them, right?
Well, it's asking for as everything under the sun that we can ask for within the structure of these on this screen, 5 types, and then determining kind of how we want to be able to move forward. So to that point, ultimately, the recommendation could be, we have 1 PPO now, we might be saying, hey, we think there should be more than 1, or whatever the scenario might be.
I mean, I think maybe for me, I have to reread it, do a little more research, and then maybe I could have some better feedback. But I think this was a good start, and I'm glad it wasn't too many slides to data. So thank you for that.
Yeah, I think everyone needs some time to absorb the information, look at it. Maybe you can email to you guys any questions or changes or things that change.
That's a good idea.
Yeah.
And one clarification, we aren't asking for the deductible HMO either at this point. No.
But it could be proposed. Anything could.
One of the important things that Paul brought up as well too is the fact that we're always asking for duplication of the current plan design. That's important. That's our benchmark. That's how we compare everything. And if they do show an alternate plan, it's the way that we can gauge it back to the benchmark. What's the difference in value? What's the difference in cost? And so forth. So fundamentally, we always need those benchmarks.
But they're not required to provide an alternative plan either.
No.
Any other thoughts or comments or? Okay. Awesome, thank you. All right, so moving on to report 2502 projects and activities. Okay.
Good afternoon, JLMBC members. This is the projects and activities report for the month of December 2024. So on page 1, we have a few Anthem network updates for you all. Late November, Anthem had notified the city of some ongoing contract negotiations with Scripps Clinic, Suter Health, and Sansom Clinic. These contracts were set to expire on January 1st of 2025, and for at least for Sansom Clinic, they have 2 expiration dates: January 1st and March 1st of 2025. I do have one last minute update for this. After this report was finalized, Anthem did advise us that they were able to reach an agreement with Suter Health and Sansom Clinic for new contracts. So for Suter Health and Sansom Clinic, there will be new contracts in place, and affected members will be notified of the change. But at least for Scripps Clinic, that agreement was set to expire on January 1st. On the second page, we also have another network agreement update. This is the opposite. Anthem notified the city that they had added 2 new providers to the network, Perlman Medical Group and Perlman Clinic. Included as an attachment to this report are some overview information on both new providers. Moving on to the project updates. For the December 2024 paycheck, employee benefits discovered an error in the payroll file where that affected a group of employees. Essentially, for employees who were due to have a increase in their supplemental life or supplemental disability benefit. What had happened was that their current life insurance or disability insurance deduction amounts were supposed to be stopped, and a new deduction entry was supposed to be added to take its place. What didn't happen was that a stop date wasn't added for the existing deduction. So the employee essentially had their existing and new deduction amount applied to their paycheck. And to compound this issue further, there is a display issue with the Workday pay slips where it took these 2 entries and it displayed it twice. So the employees were, not only was there an increase to the employees' deduction amount, it was being displayed twice, causing employees to think that they were also deducted twice, which is not the case. So we are in the process of, the refund process was completed earlier than anticipated. But the display issue will take a little bit longer to fix. We are going to be sending communications to employees to advise them of the issue and the display issue. Moving on over to page 3, we have a HRP update. As previously reported to the JLMBC, the LAL benefits eligibility requirements rule have resumed, starting with the paycheck for January 8th. Any employees who do not meet eligibility criteria, which includes the meeting qualifying hours, and does not have protected status, will be billed for the full cost of the premium. The city subsidy will not apply in this case. Staff have been sending communication to affected members about the change. Employees who do not meet qualifying hours will be receiving a bill in the next few pay periods for the city subsidy and any deduction amounts that are due. Moving down to an OE update on page 3, we have a follow-up on a question that was brought up at the last JLMBC meeting regarding the affected employees who did not make a change after receiving the notice about the removal of the benefit age reduction factors. So we had previously communicated that there were about 800 employees identified who were going to be affected by the removal of the benefit age reduction factor. Now, of the 800 or so members, on page 4 are some statistics that we found when we did our audit. So about 76% of the employees took no action to change their supplemental life insurance benefit for 2025. About 15% chose to reduce their existing coverage to a lower coverage level for 2025. About 8% opted to not re-enroll for 2025 at all. And about 1% of the affected group members retired or no longer works for the city. For the second update on page 4, we have an ACA update. So we're currently working with Benefitscape to prepare the 1095 forms for the 2024 tax year. We are still working with the consultant to compile the data and to audit the data, but we anticipate completing this process in time for the forms to be mailed out by the January 31st deadline. And lastly, we have a staffing update. At the previous meeting, I had mentioned that we had interviewed to fill the benefit specialist as well as the HIPAA compliance officer position. Since then, we have made offers for both positions, and our selected candidates for both positions accepted. So Araceli Goza had accepted the in-place promotion offer to be a benefit specialist, and Mindy Dwyer accepted the promotion offer for the HIPAA compliance officer position. And that concludes this report. I'm happy to take any question and also any items you may have for the calendar.
For the ACA, I know there's a new rule where you don't have to mail out the 1095s. Is that 26 or when is that? I can't remember the specifics.
I will have to check on that.
Okay.
I believe there is an option to email it, but we are not set up to provide 1095 forms electronically yet.
Okay. Also, can we get confirmation? I know Anthem is in the room. Can we get confirmation that Scripps is no longer? Is that?
We're still
Okay.
actively in discussions with them.
Okay.
We'll make sure to keep you up to date. As far as the members that are the city of Los Angeles members that are assigned to Scripps, there were none that were assigned to their medical groups. And there was very minimal, I believe, less than 11 that utilized their facilities within the last 12 months. So
Okay.
given that Scripps is in the San Diego area, very low impact to the city of LA. Unfortunately, as Sean mentioned, we were able to bring on a new medical group, Pearlman, with over 1,000 providers in that San Diego area.
Okay. Thank you. Do we have any other questions on the report? Okay. Thank you. Request for future agenda items. Marlene, go ahead.
Yeah, so I do have a request under just some things to get on the record, and I think some of them would come along with maybe explanation in the future agenda. This has to do with the draft RFP. I was under the impression that we were going to see a final of that today, and a little bit disappointed that we didn't. So I do want to know if it will be brought back to us and when. There were some unaddressed concerns in the first draft that I thought would be addressed on the final. And again, for future agenda, at what point do we provide input or hear about any copay changes? We talked about the HSA. I want to put on record that, you did mention the default may change and that it would probably be the lowest cost if there is this HP, the high deductible option implemented. That to me seems that would be the low cost and members would be placed in there as a default. I have a concern with that. And as far as even just members not having the education on how to even manage that type of plan. We talked about a goal of minimal disruption, but in the draft RFP we saw, it's not a disqualifier. And then a little bit that we kind of talked about, and you said like anything can be proposed. When the plan design seems a little bit like on the liberal side in that regard, it raises a concern that the proposals might be considered incomplete by you all. And it might leave us in a similar situation that we were in last year. And for the alternative options, there was really no scoring criteria. So again, I just confused as to how that's going to be evaluated, and is that going to leave us back in the situation that we were in last year? So I know that's a lot, but maybe as we move forward with this, some of those things could be better explained.
I don't think we can speak on those now,
No,
correct?
not now.
So at the February meeting, I think we could bring those all back.
Thank you.
Any other clarification for the current HSA? What company, what vendor is managing that for us?
Our flexible spending accounts are through Ameriflex starting as of January 1st. WageWorks is still our vendor, but they're only for transit and parking.
And the funds are by choice, the employee chooses it as a deduction and then
Correct.
Ameriflex is
Yes.
gonna be matched.
Whatever no, for the flexible spending account, there is no match.
No, I mean, it's a voluntary contribution that the
Oh, yes,
employee
sorry.
has chosen
Correct.
and the vendor manages it. So when you said earlier, Paul, that we only pay the premium, that the language is that we only pay premiums and that's why we can't have an employer match right now. I thought the language of the contract said that there's subsidy is equal to the value of the premium.
When I said authority, I meant the authority of us to be able to pay subsidy at all. So it is up to the maximum of the Kaiser plan that's written as the premium. And it is for the each individual MOU has that language in it right now, as well as the ad code. I think the understanding or the concept of the HSA would not be that it's a premium. It's paid directly to the employee for their use of anything, which could include premium. But it's definitely something for us to bring back. Yeah, and just so I'm fully understanding the request, so it would be a comprehensive request of how our setup currently is and what our options would be should the city actually decide or this committee decide to adopt a HDHP.
Correct.
The next steps afterwards.
Yes, thank you for translating.
It's an important skill for sure. All right, anything else for future agenda? All right, so we've got our next meeting. Wait, I took my glasses off.
February 6th.
February 6th, thank you. Thought I would wing it there without my glasses. February 6th, all right. Thank you so much.
Thank you.
Oh, you,
Oh, no.
okay,
Sorry.
2:54, all right. Thank you so much.
That's